Hey everyone, good afternoon. My name is Ann Conrath with Avant-garde Health. Welcome to our next webinar with the Avant-garde Health Team Collaborative. It is our last one for the year of 2025. Just yet getting a few weeks ahead of go live date for team on January 1st. So we're so excited that you're here. Thank you so much for registering and joining for us. We are so excited for this conversation today that's going to be focused on independent surgeons and hospital collaboration, specifically for team and in bundled payments. And certainly in our conversations with all of the health systems that are participating in team in the hospitals, a significant majority of folks have their surgeons are contracted, meaning that they're not employed. And the strategy there, I think, just is different than with surgeons that are employed. And so really excited that Dr. Michael Grawi is joining us this afternoon to give that perspective and thinking how are independent surgeons thinking about bundle payments. What are some things that they're really looking for in a partnership with a hospital? Certainly around Medicare bundle, but then also beyond that. So this is really going to be the way that hospitals are reimbursed going forward. So I think that team is really giving us an opportunity to do something, at a much larger scale than what's been previously done. And the stakes are just higher for team than they were previously in CJR and BPCI. And so I think this is really an opportunity to perhaps do something different than has been done before, just given that those relationships can be a bit challenging. Want to do some brief introductions. As I mentioned, my name is Anne with the Avant-garde Health team. This is, I think, maybe our eighth webinar. So, yeah, this has been such an incredible experience and connecting with folks who are doing this work. So really grateful that you all are here and excited for the conversation. Porter, I'll toss to you.
Yeah, thank you, Ann. Great to see everyone again. For those that have joined us before, and welcome to those that are new and joining us for the first time. My name is Porter Jones, and I'm the Chief Medical Officer at Avant-garde Health. Derek?
Hey, good afternoon, everybody. I'm the CEO and founder for Avant-garde Health and based in Boston and very grateful for everybody's active participation this year as part of the Learning Collaborative. We've been supporting organizations in bundle payments since 2016 and have written about our work in Harvard Business Review and JAMA. So excited to be organizing this Learning Collaborative to help everybody prepare successfully for the TEAM program coming up in January.
Absolutely. So wanted to share a bit of updates here. So for the collaborative, we have been doing monthly educational webinars since May. That will move to quarterly in 2026. We have really been excited about the enthusiasm for the collaborative with all the different administrators and surgeons that are participating in team and beyond. And so we would love to continue that same energy moving into the program once we're live in January. So really, really excited to offer that. And the assets that we have will continue to be shared via Dropbox, as well as sharing them individually for folks that are not able to access that. And then specifically for our customers, so we have been so excited to begin onboarding a ton of health system customers for team to support them in a variety of ways, both operationalizing the program in team as well as on the data analytics side. And so we'll be offering some kind of exclusive services and opportunities for our customers moving into 2026, kind of still underneath the collaborative umbrella. Meaning that we want to support folks to network and connect with other people who are doing this work. And so those are some of the things that we're going to be offering for our customers next year, which is we're really excited about. Again, we'll be having those general webinars on a quarterly basis in 2026. Excellent. Another housekeeping thing before I'm excited to introduce Dr. Grawi is that as we are going through Dr. Grawi is going to give a bit of information about himself and his background, and then we're going to do kind of a significant Q&A on a variety of different topics in bundle payments. So as we're going through that, if you have questions that come to mind, please enter them in the chat. We're going to be moderating that throughout. So please, this webinar is for you all, so please feel free to ask the questions that are important to you. And so with that, I will turn it over to Dr. Grawi to share a bit about himself and his experience in bundle payments, and we'll go from there. Dr. Grawi, I'll pass to you.
Thanks so much, Ann. Appreciate it. And thanks to the Avant-garde team for having me. Really excited to be here today. And to everyone that's in the audience, please feel free to jump in with questions, as Ann mentioned. So my name is Michael Greiwe. I hail from Cincinnati, Ohio. I'm the CEO and founder at Healthcare Live. We are basically a virtual platform that cares for individuals across the country that are a part of self-insured employers. I'll get into more of that later. I'm also a surgeon, shoulder and elbow surgeon at OrthoCincy. I direct our Cincinnati Shoulder and Elbow Fellowship. We have one fellow each year that comes and trains with us. I work with a couple of other surgeons around Cincinnati to do that. Also big into research and director of orthopedic research at OrthoCincy. Published some articles and textbooks in the past and developed a rotator cuff sparing shoulder replacement, which is really exciting for patients with shoulder arthritis. So glad to be here and excited to talk to you all about my experience in bundled payments. We actually have quite an extensive experience at Healthcare Live on bundles. And I'll talk to you a little bit about Healthcare Live at this point, but also did a lot with BPCI-A at OrthoCincy as well, and so can comment quite a bit on the surgeon perspective here. But Healthcare Live was formerly known as Ortho Live. I founded that company in 2017. We basically are a comprehensive 24/7, 365 days a year, digital, virtual, and in-person care solution for managing injuries across all 50 states and across the world. We contract with about 4.5 million lives, and we have about 600 employers worldwide. Our mission is really together with our partners, we're driven to improve access, quality, and patient satisfaction for patients and organizations. And we do that in a value-based care way. So you can imagine that bundles are a really big part of what we do. Let's go to the next slide. So here are some of our trusted partners on the employer front. A lot of these names you'll recognize. Most of the larger self-insured employers, they're very cost conscious, and so we'll talk about that today and why it's so critical for hospitals to start to recognize that bundled payments are a big part of the employer's armamentarium, and it's so important for employers. They probably carry about 70% of the total incurred costs from a medical standpoint across the country. When you look at all-in costs, employers cover about 70% of that, and so self-insured employers are very interested in how bundled payment can help them, and I think hospitals that recognize this will gain a lot of referrals in the future. Let's keep moving. Just to give you a picture of who we are, I wanted to throw up this slide. This is really important to me and why we founded the company. So just to give you a look at kind of our value system, we're very big on quality. We uphold the highest level of patient care integrity. We are fully transparent in everything that we do and responsive. Our team never misses an opportunity to respond quickly to a patient question or concern that someone has. So just give you a little bit of a picture of, who we are as Healthcare Live and what we're trying to do.
Awesome. Thanks, Dr. Growie. And so with that, I'm going to move into the Q&A portion of our discussion. And so where I wanted to start, Dr. Growie, was just now that folks have an understanding of your background and your experience, I wanted to dig into a few hot topics about bundled payments. And I think it would be helpful for folks to understand where you stand on bundled payments. I think as an effective concept to decrease cost, improving patient care, because I think there's a lot of frustration and negativity about bundled payments, especially what we saw on BPCI Advanced, especially with the lower and lower target prices that caused exodus from the program, leading to kind of the proverbial race to the bottom. And so would love to hear kind of where you stand on bundles if you think if this is good for us as patients.
Yeah, thanks for that question, Ann. I think, for me, I'm overall pro bundles, but I've heard a lot of my surgeon friends talk about the race to the bottom with bundles. And so realistically, we are trying to overall decrease cost, but there are, I think, some good upside potentially with bundles. And particularly when you talk to our employer partners at Healthcare Live, they're very excited about the opportunity to utilize bundles to help themselves, lower their overall healthcare costs. And so As we look at bundles as a whole, and we talk about, patient outcomes and quality metrics, and really driving referrals into the sources where high quality exists, and good outcomes exist. For those players that are out there that are able to deliver on quality and low cost, their volumes are going to skyrocket. So, as a provider who really focuses on value, I'm extremely excited about bundles. I think they're a good thing. But on the flip side, if you don't perform well in bundles, you can get burned, and so it can be it can be a negative situation. But as long as you're prepared and I think ready to do good work and have good communication with your patients, I think there's a lot of upside. And so I think what we'll find as providers is that there's going to be a big dichotomy between the low performing providers and the high performing providers. The high performing providers are probably going to do better than they were doing in the past, and we found that with BPCI as well. At OrthoCincy, we have some good experience with that, and I think when we performed well, you saw a good amount of cost reduction overall for the patient, but then tremendous upside for the provider. So that was
Hmm.
good.
Yeah, the finances definitely have to make sense there to participate. And so thinking about collaboration with the hospital. So I think in a lot of the conversations that we have had, health systems are thinking about protocol development. I think a lot of folks are starting on the post-op side, but they're also thinking about that on the pre-op side as well. So curious to hear from you, with that collaboration with the hospital, how much are you wanting to be involved in those conversations, knowing that this would kind of be like a hospital-specific protocol? Yeah, would love to hear more there, kind of how you would want to be approached, the level of engagement that you would want on the clinical side.
Yeah, it's a good question. I think for me as a surgeon, the biggest thing I'm afraid of is being left out in the
Mhm.
conversations, with the hospital. I think, and my surgeon partners are very much on board with that. We want to have a seat at the table because, these are our patients that we're typically bringing to the hospital, and I think, a lot of the surgeons are, they're contracted with the hospital, meaning that, not directly employed by the hospital, but they're bringing cases to the hospital. And so these are our patients that we see in our practice. We bring them to the hospital to do, good work and good surgery, and then they go home. But, from our perspective, we're going to be highly involved, I think, in the post-acute care. And so getting involved in protocols, getting involved in communication, having alignment around, whatever the stakeholder interest may be, from a surgeon perspective, from a practice perspective, it is really important. So one thing, from a surgeon's perspective, I think is we really want to be involved in the conversations. We want to have a seat at the table. We want to have good conversations with the hospital leadership so that everybody's aligned. And I think that'll go a long way from a patient care perspective too. But that's I think what you'll hear from most surgeons. We want to be able to sit down and have a conversation with the hospital as you guys develop your protocols and you develop your care coordination and all that around bundles.
Got it. And I think that was really helpful just in our conversation before our conversation for today was that the fear, kind of the perspective of independent surgeons is that you don't want to be told to do something in regards to your clinical practice. And you don't want to be left out. And I think that's really helpful for administrators to understand as they think about what their strategy is going to be. Another thing that I would love for you to speak on is, if you were approached to participate in a bundle like this, what do you need from the hospital to be successful?
Yeah, it's a good question. So I think the biggest thing that I saw with BPCI, that worked really well is we had nurse case managers that basically would track each case, and every so often they'd reach out to a patient, even if they weren't having a problem, they would reach out and they'd find out how that patient was doing. Having that care coordination and care navigation piece at the hospital end is going to be critically important. And then having like direct lines of communication back to the surgeon if something's not going well, is very important too, because your surgeon is either going to be your champion or your adversary in this whole process, right? And if
Oh,
we get a phone call that a patient is maybe they have a red, swollen, hot knee, they can either say, well, go to the ER or come to my office, let me take a look at you. And the better method, particularly when you look at bundles, is to have that patient be seen in the office. Maybe we can start them on oral antibiotics. Maybe it's a normal post-op knee that doesn't need to be admitted to back to the hospital. All of these things are really important to involve your surgeon in, and the protocol development, particularly as it relates to the nurse case managers, is just really important to make sure that those lines of communication are open before the whole process starts. And so, yeah, you bring up a good point. But for me, it's like, okay, first of all, we want to have our protocols set. Second of all, we want to meet those nurse case managers to make sure that we're, on the same page. I want to exchange my
okay.
number, with them. I want to make sure that we're all having, that this is truly a team approach, right? And so, um, but yeah, that's what I'm looking for is to meet everyone involved in touching that patient because ultimately I want that communication to the patient being on brand for me as a surgeon too.
Mm.
So that's important.
Yeah, and just establishing sounds like one of the important things to work out there if the hospital case manager is going to be managing that patient post-acute is like how do we communicate when there's a patient issue?
Right. Absolutely.
Yeah.
That's the biggest thing that I'm worried about, right? Is someone else telling my patient what to do? Or are you going
Mm,
to involve me in the decision making? Um, I want to make sure that my patient receives the best care possible. And most of the time that's coming back through my office, not going to the ER.
Okay. I think that's really helpful. Yeah, because I remember when we were talking, like, I think one of the interesting things that you had shared that I haven't heard from anyone else was like with the incentive that really flips the script within bundle payments is kind of what the status quo is that, you're just more focused on having the surgery go well. And if I don't hear from the patient, that's a two thumbs up.
Right.
And that this is completely a 180 from that strategy and I think perspective of patient care. Um, yeah, which I thought was really helpful for to have. I think it's helpful for hospital administrators to understand that that's how y'all have traditionally thought about the patient care. And so that
Yeah.
this whole perspective is completely different. And I think it's helpful for them to know where you're coming from.
Yeah. The fee for service environment is very much you know, you see the patient once and then you don't really talk to that patient, again. The value-based care, bundle situation is very different. We want to be monitoring them. Ultimately, it ends up driving great care for patients because they're getting touch points and they're getting to communicate with the care team frequently. At Healthcare Live, that's one of the things we've really focused on is like, we will contact the patient after a surgery almost daily, which seems crazy. It seems like a lot, but it's great patient care and they know exactly what they're supposed to be doing. They know what, might hurt them. So the communication is that much better. But in fee for service, it drove other incentives. The incentives were, you know, try to decrease the amount of time that you end up having to spend with the patient. Not that we want to
Mhm.
do that as providers, but that's just the reality. It's sort of like that. Those were the incentives. The incentives were to, see a patient, charge for that visit, see them again. You have sort of a 90-day global period. So you see them as infrequently as possible. Here it's the
Mhm.
total opposite, which is way better for the patient because now you have multiple touch points. If there's an issue, we'd find out about it early and we get, ahead of situations. So the old system's more reactive. This is more proactive. I definitely think if I'm a patient, I'd rather be in this system, but um,
Mhm. I think
another,
that's helpful. Go
yeah.
ahead. I'm sorry.
Oh, I was going to say another thing that we talked about before was just what I'm looking for from a hospital perspective. If you have JCO certified programs as an
Mhm.
independent surgeon, and I know you're rolling out a bundled payment program, like this team's approach that you have, and you have certifications in total joint or you have certification in spine and shoulder, like my local hospital does. I'm very excited about that because I know that they're going to get great care afterwards, and that's likely going to translate in less readmissions and all the great things that go along with that. So, anyway, I thought I'd throw that out there too because it was something that
Yeah.
we talked about.
I think that's a good take of just kind of building that trust of like this is something that we're, that is a priority for us as an organization. Yeah. that absolutely makes sense. One topic I want to get into is engagement and gain share. So, a fun topic in bundled payments is gain share. And not just the financial, well, we can talk about the financial gain share piece, but I also want to talk about just engagement because teams are or hospitals are not going to get paid in team until 18 months after go live. So it's a huge lag. And then it's just an annual basis after that. So like when we think about, the positive reward for doing all this hard work, like it's not frequent. And so I would love for you to share, Dr. Growy, just as hospitals think about their surgeon engagement strategy, what are other things that are important to y'all besides, of course, having an additional check for your additional work? But I would love for you to share what else should they be thinking about because those contracts are not even in place right now. I don't think for the vast majority of health systems in terms of like a financial gain share. So they really need to be thinking about what else can we be working on in engagement for together.
Yeah, I think, you know, we all went into medicine to try to deliver great outcomes for patients, right? That's the whole thing. And for me, obviously it's important to be aligned on the financial side. So obviously that's a given. Beyond that, as a surgeon, what I'm looking for is great communication with the patients. I want to make sure that the patients feel like we are doing a great job with their surgeries. And additionally, I want that to be demonstrated visibly with some type of data because as this goes along, you can imagine, the government right now is thinking, okay, let's do bundle payment. We're going to build on the BPCI A program. We're going to, take this to the next level with surgeries with hospitals now. But you can imagine a future where outcomes are now going to be required, right? And those patient outcomes are super important, and they may end up driving the next level of evolution in this whole, bundle payment, scenario that plays out. And
Mhm.
so what's important for me is I want to make sure that I have documented outcomes on my patients, not just the financial outcomes, but what about their outcomes with regards to their shoulder replacement that I just did? 3 months later, if they have a score that's really good and averages out nicely across the country when we look at, comparisons, first of all, it's great for marketing for the hospital. But second of all, it shows me that we're doing a great job and maybe this program is really working to influence outcomes. And what would be cool is to see, before we implemented this, new Teams program and after, were we able to leverage better results for our patients through the new Teams approach? It would be really great to be able to see that because I do think in the long run it is better care, it's better for patients, but how do we demonstrate that? So as a surgeon, I really want to see those outcomes, not just on the financial side, but really on the clinical side too.
Okay. And when we think about, and that kind of leads me to think too about like data analytics and how much you want to be looking at the data. So we know with the claims data, it's going to be refreshed, once a month. Um, how often, just thinking like from your perspective, you're in a bundle payment program, you want to be looking at the data. How often do you want to be looking at that data in terms of, how are we improving? Where do I have opportunity to improve? I think that's another thing that I know health systems are curious about is just kind of the cadence of meetings, knowing that y'all already don't have any enough time. So yeah, I would love to hear your perspective there.
I think as you start this program, a monthly cadence is probably very reasonable. Surgeons are going to want to know how things are going. And we did that with BPCIA as well. I remember doing that, and we had monthly meetings. And then I think they kind of progressed to more quarterly meetings. So we started to see, quarterly meetings kind of crop up as we kind of got farther along in the program. But we have definitely, I think, encouraged sort of a monthly cadence here. It's good because you want to catch things early. If something's not working, you want to be able to catch it early enough. And I think that's probably good for the first year. Beyond that, you may be able to move to more of a quarterly cadence, but that'd be my take on it.
Okay, that's helpful. Um, and then another cute thing that I wanted to talk through would be just kind of barriers. Because I think it's important just to be honest with kind of a lot of the relationships that I have certainly heard about in the market between independent surgeons and hospitals. And I think again, team gives us a new opportunity. I think it's a new opportunity to do things differently than perhaps hospitals and independent surgeons have done in the past. And so, in your opinion, like there's a lot of things on the to-do list for hospitals in preparing for this program. Where do you put like surgeon engagement on that list in terms of like what they need to prioritize on a scale of 1 to 10, let's say?
Well, a good surgeon is going to really help drive great outcomes for you. A bad surgeon could tank the program. I mean, ultimately, if you have a surgeon that is, you know, really not engaged and they, want to basically do things the way they've done it before, they don't want to field any phone calls. They want, most things to go through the ER because they're too busy in the office. It's going to really kill the program because when a patient looks to what to do when something's wrong, they call the surgeon's office.
Mm-hmm.
That's what's going to happen. And despite having care navigators and as many of them as you can have, they still will trust the surgeon. If the surgeon says go to the hospital, go to the ER, or you need to be admitted to a short-term nursing facility after surgery because that's the way I do it. And I have a relationship with this SNF for the last 10 years. That is a problem. That's going to result in disaster for the hospital and potentially up to 20% of loss, right?
Mm-hmm.
That's going to be serious. So I would rank that, these surgeon relationships up there pretty high for hospitals as they prioritize things. I don't know if it's a 10, but it's pretty close in my opinion. I think you're up there in the 9 to 10 range probably because one person could really, mess with your whole outcome.
Mm-hmm. Yeah, and that's where it makes me think too about when you're talking about readmissions and given that example a few times. That's one of the things that I know a lot of organizations are focused on, and some of the analysis that we have provided is looking at their readmissions, 1 to 10 days post-op. And the call cadence that you had shared that you're implementing with Healthcare Live, I think is helpful for folks to be aware of. Just that that's an option where you're doing a daily phone call for the first, you said first 7 days post-op.
Yeah, it's actually we have a couple of different employers. A lot of them go back onto a vessel. So these are cruise line, um, you know, uh, crew members, and so they'll go back. And so usually it's somewhere between 5 to 10 days post-operatively. But until they get back on the ship, we are checking in daily with them to do a lot of this. So it's a daily cadence until they return back to their home environment essentially.
Got it. Okay, yeah, I think that's helpful for folks to know. Porter, I want to toss to you anything just from your experience in hospital administration and being a physician yourself. Yeah, curious if there's anything that has jogged your curiosity about different types of arrangements and how folks can best collaborate.
Yeah, so I have a few, thank you, Ann, and this has been great. I have a few questions just on some of the nuances. One, in regards to technology, are you looking at either working with the hospital or other third-party vendors for remote patient monitoring? Or are you really just doing, human-to-human interaction? Just curious where you see that could play a role and if you're already engaged with groups that can provide that service.
Great question. And yes, the answer is yes on that front. So we actually utilize kind of what we call a remote therapeutic monitoring. It's a little different than remote patient monitoring. On the orthopedic side, we really are focusing on um, basically digital technology that allows for physical therapy to be employed and for exercises to be done, and also gives the patient a chance to notify us when there's a problem. So, Healthcare Live does use that, and I think it's a great technology, one that we've spent a lot of time working on. And there's a lot of different vendors out there. And I think the remote patient monitoring piece, which is where you get to monitor vitals, is really awesome too. So don't want to leave that out, but we focus more on the remote therapeutic monitoring side of things, where people can start to do some exercises and also notify us when there's issues going on. But great question, and the answer for us is yes. We do like that technology, and we find it's very helpful for patients.
Right. Do you find just we've got people from all over the country, do you find that there's a certain subset of the patient population where that works best? I'm thinking, age range, have you been able to track
Yeah.
that, or does it seem to work well for all patients across the board?
Well, what's interesting is I've found even elderly patients are excited about using the technology. It is very simple to use, but there's probably a sweet spot from, 40 to 70 where it's very good. And then over age 75, it becomes a little bit more of a barrier. And there's more phone calls that are, leveraged, for that patient population. But I think, after COVID, what happened was everyone kind of got used to digital technology and digital tools.
Yeah,
Most people are very comfortable using them. Some of the barriers still revolve around Wi-Fi access, and in some rural areas, you just don't have great broadband, and so that ends up being more of a barrier in certain areas. But I think you're right in that some patients still struggle a little bit, but overall, the patients have really grown to accept and utilize digital technology and digital tools a lot better than they used to.
that's great. Thank you. We did have a question from the audience from about a half hour ago, so we may have to rewind just a little bit, but hitting on post-acute care. So we have a question, and I'll read it, and would love to hear your thoughts. The question is, what if our only post-acute care option are swing beds, which cost 10 times as much as a SNF, but have much better quality? What is your take on that?
Well, I'd ask the question, I guess, about whether or not there are sniffs locally that they can use at all. But what I would say is in that scenario, what I'd look at is sort of a bell-shaped curve, right? And you have the majority of your patients that would probably do just fine if they needed to go to a sniff, they could go to a sniff. Where you might need the high quality is your high risk patients. And there's some great tools out there. I know Epic has a great readmission tool. If that patient is a high risk readmission patient, you want to drive them, even though there's excessive costs, maybe to that high quality, bed, because ultimately they're going to hopefully drive down their chance of readmission and improve the outcome of that patient, and that'll really save you in the long run on your bundle. However, you can't send everyone there that may need a sniff because most of the patients are, relatively low on the readmission front, and if you've got a good care navigator that's following closely on that patient, you're probably going to be in pretty good shape. But I would say there's probably a certain percentage of those patients you do want to keep in house and make sure that they have the great care, but it's probably a certain subset, and you probably want to figure that out as you go along. But I'd be careful, sending all of them that direction if you can.
Okay. So it sounds like the decision tree is if there's a high chance or probability for readmission, go ahead and utilize the more expensive bed. Otherwise, try to divert somewhere else.
Hmm.
That'd be my algorithm.
Okay. All right. So staying on algorithms, we've talked a lot over the past year of care protocols. So focusing on orthopedics, how do you see that being done where you're at? How are you driving that within your hospital, your colleagues? So you have some sort of standardization, and some sort of protocol that is being followed by the group that is in conjunction with the hospital. This has been a hot topic of how to create those. What is the process? Who is involved? And what are the outcomes of these protocols as time goes on?
Great question on the protocols. So first of all, I think having open lines of communication is important. Obviously, there's going to be a cadence to communication with the patient from the hospital's perspective. This is the hospital's program, and therefore, I think most of the hospitals are going to have their nurse case managers and care navigators all over kind of the patient communication. Once the patient is communicated with, I think the surgeon has their set time periods that they're going to follow up on the patient. Typically, 1 week, 6 weeks, 3 months. Those are typical time periods for follow up. They also will schedule physical therapy sometimes. We are using digital physical therapy tools sometimes as well. So, in certain cases, you may have a surgeon that has a different protocol from a physical therapy perspective, but what I'm envisioning is sort of the hospital will have their cadence on follow-ups. The surgeon will have their cadence on follow-ups. Once someone identifies that there's a problem, that's when I think we have a care plan where the surgeon team gets notified. It may be the PA, it might be, depending on the group, it may be the surgeon themselves. Um, we all want to be very involved in the communication process. So having that shortcut to be able to get into the surgeon's office is very important. We don't want our nurse case managers calling the front desk and trying to get to the surgeon that way. We need communication tools like a haiku with Epic, or potentially even just a cell phone number if that technology doesn't exist in your infrastructure, to be able to communicate with a surgeon when there's a problem. So I think really highlighting kind of the typical cadence. I would say daily follow-up is ideal, from a case manager perspective. But if you can do that twice a week, even, that's great. And then the follow-up kind of gets a little bit stretched out after the first 10 to 14 days. Most readmissions happen in the first 2 weeks. You just have to sort of stay on top of things like, from the get-go, and then you can sort of extend it out a little bit longer. And I'd see maybe even a once a week check-in after that.
Yeah. If
That's great. So as we approach Gen 1, oh, go ahead, Dan.
No, it's all right. There's a
Oh,
slight delay. So you go and then I'll go after you.
oh yeah, sorry. What does that strategy and planning look like as we approach Jan 1? That interaction between the surgical staff, the hospitals, who is involved. Love to just understand how you're planning for that from an operational perspective, just to get that, because it sounds like you've thought very well of how that needs to be implemented and what needs to be implemented. How is that partnership done between now and let's say even end of January as the program rolls out?
Well, I think what's happening right now across our local hospital system is that they're reaching out amongst the surgeon teams to have sort of staff meetings where we have the hospital team members that are in charge of orthopedics and neuroscience. That they basically, are under one umbrella in our hospital system, and they're creating these touch points where we're sitting down at a table, we're going through the protocols, we are, communicating about how this is going to play out when a patient is deemed to have an issue. Who gets the communication, who gets the phone call. And we use Haiku, and so it actually works out pretty well. They just will text the patient name, we get information, we're going to have them come into the office. But it has to be really specialty specific. So what I would advocate for, and something that we're doing here, is, you have your hip and knee team, and they sit down with the hospital administrators and really come up with a game plan, about how they want their patients to be communicated with. Everybody kind of comes up with a game plan. And same thing with spine, and same thing with shoulder. As we look at, these surgeries that are going to be, bundled together. And so anyway, that's kind of how I would advocate for these planning sessions to go. And then, once we hit January 1, there's probably going to be some tweaks, and there's going to be some changes. And so I think we all have to be flexible with the fact that, it's not going to be a perfect rollout, but as long as we have sort of the pieces in place, it's just important to sit down and communicate. And I also think that, as those conversations happen, naturally, there'll be some of the gain share conversations that need to happen as well.
Great, thank you.
And then one parting question, Dr. Growy, is what advice do you have for either independent surgeons or hospitals that are thinking about entering into, a partnership for team? What's one thing that, folks should be really thinking about?
So I think as we're wrapping this up, one of the biggest things is that this is new, but a chance to really connect with the surgeons and also the hospital. If you're the surgeon looking at this is a fresh chance to work together on something that can be beneficial for both parties. So having an optimistic outlook, I think, is really important as we sit down at the table and say, look, we think this is going to be really good and beneficial for our patients. How can we stand to benefit from this? Can we create a great program that's going to, end up turning out to be great for our communities? I think it's just coming at it with an optimistic attitude is so important. we can come at it with, a bunch of different looks. And I've already told you that a lot of us are worried about a race to the bottom here. But when it comes to patient care, if we can align on patient care and drive some great outcomes for patients, and I think everybody wins, and you end up having more referrals in the long run. And these employers are starving for great bundles, so they want that. And this is going to end up, allowing this door to be opened. And ultimately, if you want more referrals from commercial payers, and we're able to do a great bundled, situation, or great bundle surgery for a Medicare patient, that translates, right? And so now you can approach your employers about these great opportunities for their own employees to have these procedures done too. So it's going to grow, and value-based care is sort of here to stay at this point. So pretty exciting times.
Awesome. Well, Dr. Garvey, thank you so much for that, those parting words, and for all of your expertise and experience in sharing with us this afternoon. Thank you so much. We're really grateful.
No, thank you so much for having me, and appreciate it.
Absolutely. Derek, I'll toss to you for some parting words for our last webinar of the year.
Yeah, thank you. It's been a pleasure organizing this series for everybody this year. One of the things that we're actively thinking about for 2026 is hosting a bundled payment summit. We're thinking about doing that next September for about a day and a half to bring together everybody that'll be part of the TEAM program to be sharing expertise, ideas, learnings, from the first 9 months in the program. And we'd love to hear people's interest. Would they be excited to participate in an in-person bundle payment summit in Boston next September? We just put up a quick poll. This will help us for our planning purposes for next year. People could just indicate their level of excitement or interest. We'd be grateful if people could just click one of these buttons here on the poll before we wrap up today. And we'll make sure to stay in touch with people who do express interest to communicate what our plans may be around this if we decide to move forward with the summit. But either way, we're excited to keep the learnings going next year, and wish everybody the best of luck starting out in TEAM in 4 weeks from now.